Hello guys, welcome back to the channel. Today on Step 1 in Focus, we are going to be looking at brain syndrome. Really, it should read brain stem syndromes because all the pathologies we are going to be looking at, or all the high yield associations we are going to be looking at, will be related to the brain stem. For you to understand brain stem syndromes, so we mean things like medial medullary syndrome, lateral medullary syndrome of Wellenberg, and so on and so forth. For you to understand these syndromes, there are a few things you need to know. First, of course, you need to know the areas we are talking about. Your brainstem comprises of three major areas: the medulla, the pons, and the midbrain. These are the three structures we are considering. There are a number of things we need to remember. The origin of the cranial nerves from these parts of the brain, because if you're going to know or localize lesions to any of these parts of the brain, then you need to know what landmarks, what symptoms tell you that the problem is in the midbrain versus the brainstem, versus the medulla rather, or versus the pons. Your cranial nerves are 12 of them that we know, right? 12 of them, 1 to 12. You would remember that cranial nerve 1 and 2 arise outside the brainstem. So your olfactory nerve and your optic nerve are outside the brainstem. They have nothing to do with the brainstem, really. Then we have cranial nerve 3 and 4 that arise from the midbrain, cranial nerve 3 from the upper part, cranial nerve 4 from the lower part, oculomotor and trochlear nerves. Then 5, 6, 7, 8 arise from the pons. In fact, they are arranged from middle outwards. So 5, 6, 7, 8. That's how they are arranged. Another thing you would notice is that abducens nerve, which is cranial nerve 6, is the most medial. As a rule of thumb, you want to remember that motor nerves, pure motor especially, are generally more toward the center. Mixed nerves are more in between, and sensory nerves are more lateral. So abducens nerve is a pure motor nerve. You notice it's in the middle. Your facial nerve is mixed, it's kind of toward the side. Your vestibulocochlear nerve is purely, mostly sensory, so it's toward the side. So as we go from the middle outward, you go from motor to sensory, and mixed is usually in between. You should remember that. Cranial nerve 9, 10, 11, and 12 arise from the medulla. So your glossopharyngeal, your vagus, your accessory nerve, and your hypoglossal nerve. Once again, your hypoglossal nerve is almost purely motor, or purely motor innervates the tongue. So you notice your hypoglossal nerve is the most medial of them all. So as a rule of thumb, on the brainstem, motor nerves arise more medially, sensory nerves are more lateral. You want to remember them. So, do you know your 12 cranial nerves? Can you say them that quickly without thinking? And I hope you remember the functions of all of these cranial nerves, because that will help you. Next, we'll jump straight into the brain stems and we'll begin to look at basic things you should remember. The medulla here, which is where we are going to start, we'll start from the bottom up like that. What kind of arrow is that? From the bottom up like that. The medulla looks like a t-shirt. There is the handle of your t-shirt. It looks like that. The neck of your t-shirt, the other handle of your t-shirt, and the body of the t-shirt. That is what the medulla basically looks like. This right here is the fourth ventricle. I don't really need to put that. Oops. 1 second, I cannot draw to save my life. Okay, here we go. So if I make arches like that, I'm drawing this pretty rough because we don't have all the time to waste. Right there is a space, the cavity of the medulla, which is the fourth ventricle. You need to remember that, of course. You can put nucleus in here, put some nuclei, some cranial nerve nuclei, because all your cranial nerves arise from nuclei. I hope you remember that. You need to remember those nuclei. The first, most medial one has to be pure motor. Remember we said motor to sensory from medial to lateral. So the most medial one is the pure motor one, and we are in the medulla. So what's the pure motor nerve arising from the medulla? The hypoglossal nerve. So this is cranial nerve 12 right there. And then lateral to it, we have your dorsal vagal nucleus and your nucleus of tractus solitarius. Now, I don't need you to bother too much with the specifics of them. I just need you to know that this is a thing, right? Your dorsal vagal nucleus, your nucleus of tractus solitarius, they contribute to cranial nerve 10, your vagus nerve. There's one other nucleus I have not mentioned. It's located in the center, sort of the medulla. This is the nucleus ambiguus. This is nucleus ambiguus. Nucleus ambiguus, when we draw it, it's kind of surrounded by the reticular formation. And I hope you remember that your reticular formation is what is concerned with awakeness, right? When there is firing within the reticular formation, that's when people go, when they wake up from sleep. Somebody does not do that. Firing within the reticular formation is what does that. But this is what you need to remember from the medulla. The cranial nerve 10, vagus nerve arises from there. Cranial nerve 12, hypoglossal nerve arises from there. On the sides, we have the more sensory nerve, like your vestibulocochlear. Did I say vestibulocochlear? Glossopharyngeal and part of your vestibulocochlear nerve, actually. Because up here, on this big handle of our t-shirt, we have the vestibular nucleus. You see it right here. The vestibular nucleus. I don't need you to know inferior vestibular. Don't worry about the details. Somewhere close to it, somewhere close to it, we have parts of the cochlear nucleus as well. So vestibulocochlear nerve, kind of parts of it are here as well. You see the other parts in the upper portion of the medulla approaching the pons, right there. Then at the bottom of your medulla, at the inferior surface of the medulla, we have the pyramids. The pyramids, both of them on both sides. The pyramids. Now you would remember that your pyramids, the shape, the pyramidal shape, is what gave the name pyramidal tract to your corticospinal tract. So your pyramids are basically the same as your corticospinal tract. If you can produce this diagram, this rough sketch I have done here, that is sufficient. I need you to be able to do that, and then we can walk from here. We'll jump straight into looking at some of the medullary syndromes. The first one we'll consider is the medial medullary syndrome. What causes the medial medullary syndrome? When there is damage to the central part, the medial part of the medulla. When you have a damage to the medial part of the medulla, we call that medial medullary syndrome. Medial medullary syndrome is also called Dejerine syndrome. Don't worry about the name Dejerine syndrome. We don't care, right? But it is called medial medullary syndrome. It means there's something wrong with the medial portion, for example, of your medulla. The medial portion of your medulla. So what's going to happen if you damage the medial portion of the medulla? Well, obviously, you can see that the pyramid is involved here, right? Look at our pyramid. The pyramidal tract, I would have loved to get an image showing you exactly how it looks, but okay. The pyramidal tract is going to be affected, which is your corticospinal tract. If you affect the pyramids, then the patient is going to have hemiparesis, upper motor neuron signs. Upper motor neural signs that are contralateral. Remember that these pyramids ultimately crossed over at the base of the medulla. So they are going to have contralateral upper motor neuron signs, hemiparesis. You want to remember that. The medial meniscus is not often shown when we look at the image of the medulla, but the medial meniscus is also going to be damaged. Okay? The medial meniscus is also going to be damaged and is going to result in loss of proprioception. You would remember that your medial meniscus was a continuation of the dorsal column. We talk about the dorsal column medial lemniscal pathway. I hope you remember that. Good. So the medial meniscus or medial lemniscus can be damaged in the medulla as well, and that will result in loss of proprioception. Again, contralateral loss of proprioception. The tongue. Do you notice the nerve we saw that arises from that anterior part, cranial nerve 12? If we were to draw this properly, exactly how it should be, I'm going to put the nerve on this diagram over here. You see your hypoglossal nucleus? The hypoglossal nerve comes out like that. Between the pyramids, if we have that original image, you see the pyramid in front, and you see your hypoglossal nerve coming out just lateral to the pyramid. So this representation is not even as accurate as it should be. Like this. Yeah, between the pyramids and the olive nucleus, your hypoglossal nerve comes out like that. So when you have a damage around this region, trust the hypoglossal nerve is going to be affected, and there's going to be ipsilateral tongue weakness. So if you are doing a question and you think there is a brainstem problem going on, there's something wrong somewhere, and you see tongue deviation, the tongue always deviates to the side of the lesion, right? It's ipsilateral all the time. Once you see tongue deviation, you know that this is probably medial medullary syndrome. What causes medial medullary syndrome? A damage to the anterior spinal artery. So two things you're looking for to know exactly that this has to be medial medullary syndrome. Pyramidal tract sign, upper motor neuron lesion, contralateral hemiparesis, and cranial nerve 12 sign, hypoglossal weakness, tongue deviation. If you see those two things, you're looking at medullary syndrome. Next, look at lateral medullary syndrome. With lateral medullary syndrome, what you're looking for is loss of pain and temperature on opposite sides of the body and face. So there's loss of pain and temperature, for example, on the right upper limb or upper and lower limb, and loss of pain and temperature on the left face. Think of that. left face, right side of the body, or right face, left side of the body. I think I'm even pointing to the wrong sides of my body. But once you have loss of pain and temperature in opposite sides of the body and face, you're dealing with lateral medullary syndrome. Why? What does pain and temperature to the head and neck? I hope you said trigeminal nerve. The trigeminal nerve does pain and temperature to the head and neck, to the face. Whereas your lateral spinothalamic tract does pain and temperature to the body. So if you have lateral spinothalamic tract involvement and trigeminal nerve involvement at the same time, you are probably dealing with lateral medullary syndrome. The blood vessel that is involved in lateral medullary syndrome is the posterior inferior cerebellar artery, PCA or PICA. The posterior inferior cerebellar artery. There's going to be loss of pain and temperature because of trigeminal nerve involvement, and there's going to be loss of pain and temperature in the body because of lateral spinothalamic tract involvement. Other symptoms will be things like dysphagia, hoarseness of voice. You would remember that whenever you think of hoarseness, you always think of vagus nerve. You remember the recurrent laryngeal nerve, which is a branch of the vagus. And that is because the nucleus ambiguous is affected. And like I mentioned before, the nucleus ambiguous is the third nerve that contributes to your vagus nerve. Okay, so damage to your nucleus ambiguous will result in hoarseness of voice, dysphagia, difficulty swallowing, which is technically a damage to your vagus nerve. That's how I wanted to look at it. They're also going to present with vertigo, nystagmus, because of damage to the vestibular nucleus. Okay, it's lateral medullary syndrome. The lateral part of the medulla is what is affected here. So the vestibular nucleus is affected. The vagal nucleus, the nucleus ambiguous, is often also affected, and you see symptoms accordingly. In addition, like we already said, there will be decreased pain and temperature, which is the big thing, on the ipsilateral part of the face and contralateral part of the body. So if there's loss of pain and temperature on the right side of the face, it means that this is right lateral medullary syndrome. If there's loss of pain and temperature on the left side of the face, it means that this is left lateral medullary syndrome. So the localization of the lesion is done with the help of the cranial nerves. Okay, the localization of the lesion is done with the help of the cranial nerves. There will be decreased pain and temperature on the ipsilateral face, the same side of the lesion, and contralateral body. These patients may also have Horner's syndrome. In medial medullary syndrome, it's the anterior spinal artery. Remember, the anterior spinal artery ran on the anterior surface of the medulla. And your lateral medullary syndrome is the posterior inferior cerebellar artery. Remember that. It's also called the lateral medullary syndrome of Wellenberg. I like to say the whole name. That way I remember everything, right? All right, next is your pons. The big old pons. The pons looks like an upside down chicken feeder. That's how I think of the pons. I just make upside down chicken feeder. You can do something like that. You see that? That's what the pons basically looks like. And on the anterior surface of the pons, we have these nuclei that we call the pontine nuclei. The pontine nuclei is found on the anterior surface of the pons. So you see them right there. Now, your corticospinal tract travels along the anterior surface of the pons as well, and the corticospinal nerves scattered because of the pontine nuclei present here, but won't stress too much about the pontine nucleus. What are the nerves that arise from the pons? What nerves arose from the pons? If you said 5, 6, 7, 8, cranial nerve 5, cranial nerve 6, cranial nerve 7, cranial nerve 8, these nerves mostly arise from the pons. A lot of them emerge at the pontomedullary junction, at the junction, or pontocerebellar junction sometimes it's called. At the junction between the pons and the medulla, that is where some of these nerves arise from and leave the pons from. We're not going to stress too much about it. Some key parts of the pons to pay attention to. You see the medial meniscus right in the middle over there. Look at this nerve, your facial nucleus, your facial nerve right there as well, and other nerves that could be present. Your vestibular apparatus or nuclei are always located to the side. Cochlea, vestibular, they're all to the side. They're all sensory. They are to the sides. All right. I just want you to have a rough idea. If you're in MD2 watching this video, or I don't know which class you do neuro for the first time. If you're in the lower MDs and you're watching the video, you need to kind of learn how to draw it more detailed. But if you're preparing for the USMLE, not necessarily. You just need to remember the cranial nerves arising from these, and if the cranial nerve is medial or lateral. Okay, that way you know which part of the pons you're dealing with. All right, the first syndrome we are going to consider from the pons is the locked-in syndrome. Locked-in syndrome occurs when there is basilar artery stroke. Locked-in syndrome occurs when there is basilar stroke. Essentially, there is obstruction of the basilar artery because the basilar artery gives rise to tiny branches we call the pontine arteries, little blood vessels that emerge from the basilar artery. You may remember your basilar artery right on the anterior surface of the pons. I hope you can picture what I'm saying. If you can't picture it, please let me know in the comments. I'm going to do a very short clip where I show you the blood vessels that supply the brainstem and how they function. Okay, the key in locked-in syndrome is that these patients are trapped in their body. That is what you're looking for in a VNet. You're looking for a patient that cannot move their body. They are quadriplegic. Hands can't move, legs can't move. They can't really speak either. They can move their eyes, however. They just move their eyes. They communicate with their eyes, but they are trapped in their body. This is locked-in syndrome. The patient is conscious. Consciousness is intact. They can blink. They can move. They can do anything with their eyes, but they cannot do anything else other than move their eyes. Okay, that is what we call locked-in syndrome. And I think you can make sense of it. Imagine somebody just lying down there like that, moving their eyes. They are locked in their body. It's like they're trapped in their own body. This is what locked-in syndrome is. Next, we look at medial pontine syndrome. Medial pontine syndrome occurs when you have some other branches of the basilar artery, like your paramedian branches, affected. For the purpose of the USMLE, the most important is going to be the locked-in syndrome. Quite rarely will you get a question testing you on medial pontine syndrome. However, how do I know that a patient has medial pontine syndrome? What cranial nerve arises from the medial surface of the pons? Cranial nerve 6, abducens. And what sign will I see to know that someone has abducens nerve palsy? If you remember your SO4, LRO6, all others 3, you remember that this is how you remember the nerves that innervate the muscles of the eye. You remember that? The muscles of the eye. SO4, superior oblique, lateral rectus, all others 3. Good. So the lateral rectus is supplied by the abducens nerve. So when you have a person that has weakness on lateral gaze palsy, I'll talk about lateral gaze palsy for a different condition. When you have a person that has weakness on lateral gaze, or their eyes is held in medial contraction, the eyes is basically looking medially, indicating that the lateral rectus is not working, you know that this person probably has a medial pontine syndrome. You want to remember that. Contralateral hemiparesis plus abducens sign, medial pontine syndrome. Then for lateral pontine syndrome, if you go to the lateral surface of the pons, remember from this image over here, on the lateral surface of the pons, we start talking about the facial nerve and the vestibulocochlear nerve. So for lateral, we have facial nerve paralysis and vestibulocochlear nerve involvement, hearing loss, especially probably sensorineural hearing loss. With lateral pontine syndrome, you have loss of pain and temperature, again, on opposite sides of the body and face because of involvement of your lateral spinothalamic tracts, as well as some of the fibers of your trigeminal nucleus or trigeminal nerve. These patients will present with vertigo, nausea, and nystagmus because of vestibulocochlear nerve involvement, some ataxia because of involvement of the cerebellar peduncle, and Horner's syndrome. I'm far more interested in facial paralysis and hearing loss. When you have a patient that looks like they have a brainstem stroke and they have facial nerve paralysis or hearing loss, you are probably looking at lateral pontine syndrome. The artery is anterior inferior cerebellar artery. And finally, we get to the midbrain. The midbrain looks like a pair of shorts. I cannot draw today. The midbrain basically looks like a pair of shorts. Look at it. It's a pair of shorts, no? Don't they look alike? I think so. And the arms, you see, it looks like we have 2 feet where your legs go on the midbrain. Those feet are what we call the crus cerebri. The crus cerebri. That's the feet. The posterior part of the midbrain up there is the tectum. This posterior part is the tectum of the midbrain. The tectum of the midbrain. And the medial part is called the tegmentum. But I don't care too much about the tegmentum. I care about the tectum and the crus cerebri. The crus cerebri is like the leg of the shot on the midbrain. And there are some structures that are found on the crus cerebri. If you look closely here, you see your corticospinal tract and your corticobulbar tract, which is also called corticonuclear tract. Corticonuclear tract is the upper motor neuron for your cranial nerves, whereas corticospinal tract is the upper motor neuron for your spinal nerves. Okay? Maybe we'll talk about that in a different context. But they are both upper motor neuron. These are both upper motor neuron. Then we have some pontine fibers. We don't care too much. We have decussation of your inferior cerebellar peduncles. We don't care too much about those. It depends on the level where you are at. The structures will change. The other important structure is this black structure over here. There's a black structure on the leg of this pair of shots we call the midbrain. This right here, if you're looking at this diagram, and that is the substantia nigra. You would remember that the substantia nigra was the structure that was involved in patients with Parkinson's disease. Loss of nigrostriatal fibers in the substantia nigra was the pathophysiology for Parkinson's disease. You remember that. And then, of course, we care about the nerves that arise from the midbrain. For the lower portion of the midbrain, we have the trochlear nerve. Look at that. The lower portion of the midbrain, right there. If you take a lower section, you have the trochlear nerve, cranial nerve 4, IV, right? Roman numerals. Okay, IV 4. Cranial nerve 4, the trochlear nerve. On the upper part, the higher part of the midbrain, you have your oculomotor nerve. Cranial nerve 3, oculomotor nerve. And depending on which cranial nerve, again, lesion you have, the symptoms will differ. You want to remember that. In the medial part of the midbrain, you see, we also have your medial longitudinal fasciculus, MLF. I hope you remember your MLF syndrome, medial longitudinal fasciculus syndrome with horizontal gaze palsy. Multiple sclerosis, you remember that. All right. The first syndrome we are going to look at will be Weber's syndrome. Weber's syndrome is medial midbrain syndrome. Weber's syndrome or medial midbrain syndrome is as a result of damage to the posterior communicating artery. The posterior communicating artery. What are you looking for in a vignette to know that a patient has medial midbrain syndrome? Of course, you're looking for hemiparesis, contralateral upper motor neuron lesion especially, and cranial nerve 3 palsy. Whenever you see a person having oculomotor signs, so weakness of the eye muscles, right, apart from lateral rectus and superior oblique, weakness of your eye muscles, you know you are having a problem in the midbrain specifically. Because of the cranial nerve palsy, they will have a down and out eye. They will have ptosis, levator palpebrae. Remember, levator palpebrae is innervated by the oculomotor nerve as well. And they will have mydriasis, or what may be described as a blown out pupil. May be described as a blown out pupil. In addition, there will be corticospinal tract involvement. So these patients may have upper motor neuron signs. All right, and then the other thing you want to consider will be Perinode syndrome. Perinode syndrome. What is Perinode syndrome? Perinode syndrome occurs when there is a tumor compressing the tectum of the midbrain. When you have a tumor growing up here on the tectum of the midbrain, eventually that tumor begins to compress the tectum of the midbrain. Something we did not mention. If you look closely at the top of this midbrain, right here, you see these yellow structures. Those are what we call your inferior colliculus or your superior colliculus. We have 4 of them. The superior colliculus and the inferior colliculus. And 4 of them together, there are two pairs of each, or there's a pair of each. So 4 of them together we call this corpora quadragemina. This is corpora quadragemina. We don't care if you know that. Just remember the function of those structures. The superior colliculus play a role in visual reflexes, and the inferior colliculus play a role in auditory reflexes. The eyes are above the ears. Well, in most people, right? Are my eyes above my ears? Yeah. The eyes are above the ears. So superior colliculus, visual reflexes, inferior colliculus, auditory reflexes. That's what I want you to remember. Now, when you have compression of the tectum of the midbrain, you compress that superior colliculus that deals with visual reflexes, and the patient presents with vertical gaze palsy. On the USMLE, if they give you a patient with vertical gaze palsy, I want you to think perinode syndrome. Vertical gaze palsy, perinode syndrome. Vertical gaze palsy, perinode syndrome. What kind of tumor will compress the tectum of the midbrain? A tumor in the pineal gland. A tumor in the pineal gland. The pineal gland is very close. It's behind the midbrain. It's very close. And when you have a tumor of the pineal gland, it can grow big and compress the posterior surface of the midbrain, the tectum of the midbrain. So it's usually a pinealoma, and the most common type of pinealoma, if you're in MD pathway, you would have seen this in your neuro and in your neuro. What's the most common type of pinealoma that would be compressing the tectum of the midbrain? I hope you said it would be a dysgerminoma. It will be a dysgerminoma. The other thing you want to remember is, okay, it's a tumor, it's compressing. If this tumor continues to grow big, you would remember that the cavity of the midbrain is the cerebral aqueduct. Look at that, the opening, right? The narrow cerebral aqueduct. This same tumor can compress the cerebral aqueduct. If it compresses the cerebral aqueduct, then this may be associated with an obstructive hydrocephalus. It can be associated with obstructive hydrocephalus. So we get vertical gaze palsy equals perinode syndrome. We have a pinealoma, which the most common type, if you did a histology, would be a dysgerminoma. They also have pupillary light near dissociation, lead retraction. We don't care too much about those. I need you to remember pinealoma equals vertical gaze palsy, and this is as a result of a mass in the pineal gland compressing the tectum of the midbrain. You can call this dorsal midbrain syndrome, but perinode syndrome is sufficient. This is a brief summary of all of this. We saw medial medullary syndrome as a result of anterior spinal artery lesion. For example, you're looking for cranial nerve 12, hypoglossal nerve signs, tongue deviation, ipsilateral tongue deviation. How do you know which side of the midbrain the problem is? Look for the cranial nerve sign. Whatever side the cranial nerve sign is the side where the injury is, okay? Lateral medullary artery because of posterior inferior cerebellar artery injury. You're looking for hoarseness because of that nucleus ambiguous involvement. And of course, there'll be decreased pain and temperature. Medial pontine syndrome, usually because of basilar artery stroke or anterior inferior cerebellar artery stroke. In lateral pontine syndrome, we saw Weber's syndrome because of posterior communicating artery involvement. And we saw perinode syndrome, which is a pinealoma compressing the tectum of the midbrain. And you're looking for vertical gaze palsy. If there's anything here you did not understand, I have tried to go quickly because I'm trying to keep this video short, but somehow I just keep talking and they keep getting long. If you have any questions related to this, ask me in the comments. If there's any particular question you have done and you found difficult, send me your questions you can send them on Instagram, you can email them to me. I'm going to make a video, we are going to discuss your questions. And yeah, if you're new to the channel, please remember to subscribe, give the video a thumbs up, please share to a medical student. We are growing slowly but surely. Thank you guys. I will see you all tomorrow. Bye-bye.